A warm good morning to all of you. So, since it's a 8 o'clock session, I think it's quite early for all of us. So, thank you for joining us today. So, we are discussing various topics in cataract surgery, and I think along the way we can discuss some practical and relevant points also. So I invite our first speaker, Dr. Manasa. Dr. Manasa has completed MD ophthalmology from RP Center, New Delhi, and she's also done a long-term fellowship from Aravind Eye Hospital, Madurai. She currently works at Geetanjali Hospital and PRS Hospital in Trivandrum. And Dr. Manasa also started the operation theatre recently at PRS Hospital. She started doing cataract surgery there as well. So she'll be speaking on ocular anesthesia, the various techniques, and how to optimize the outcomes.
Good morning, a warm welcome to our IC. So the first thing in the morning, we'll start with anesthetic symphony, where our choice of anesthesia practices guides the outcome. That is the patient comfort and the surgical precision, thereby harmonizing the cataract surgery experience. So cataract is the highest volume of surgical procedure that is performed worldwide almost exclusively as an outpatient procedure. But still, there are significant differences in the adopted anesthesia practices in different parts of the world. So the key questions that we have to address are the risk and benefits that is associated with one form of anesthesia over another, and the issues related to complications of each, specific sedation strategies, the level and the intensity of monitoring required for each, and the data available to back up the same. So the year 1884 is kind of a watershed year when it comes to ophthalmic anesthesia, because that was when Dr. Karl Kohler, he was friend to Dr. Sigmund Freud, the father of psychoanalysis. Both of them were experimenting with the wonder drug cocaine. When Freud saw it as an antidote to morphine, Dr. Karl, he noticed the numbing effects of cocaine. And that is when he went on to publish it in Lancet in 1884. And in the same year, Herman Knapp, he published in Archives of Ophthalmology, using cocaine for retrobulbar anesthesia. Then later the peribulbar came, then the topical was reintroduced and so forth. So this is the broad classification of the different anesthesia technique that we adopt in our ophthalmic surgical procedure at present. Now, the choice of this anesthesia technique depends on two people, the patient and the surgeon. Now, the patient factors like the patient preference, their anxiety levels, their level of cooperation, and also the existence of ocular comorbidities like a corneal opacity or a subluxated cataract, which can prolong the duration of the surgery. If the patient is an axial myope with a staphyloma, or if the patient has a scleral encirclage in situ, there is a high risk of perforation with needle techniques. Now, if the patient is likely to get a trabeculectomy in the future, then we have to spare area for a good bleb. Then if the patient has an ocular surface disorder like an ocular cicatricial pemphigoid or a Stevens-Johnson syndrome, then we would rather not do a subtenon so that the symblepharon doesn't progress. Now, the surgeon factors like the site and the type of the incision, the complexity of the procedure, the risk of complications, the duration of the surgery, and the expertise of the surgeon. Now, the goal of anesthesia in ophthalmic surgery or any surgery in general is to provide a pain-free surgical experience, to facilitate the surgical procedure, to minimize the risk of the complication associated with the anesthesia, as well as to reduce the risk of surgical complications. Now, that thorough understanding of the orbital anatomy is essential if you're planning for any needle-based procedure. Now, the retrobulbar that was given with a 23 gauge 31 millimeter needle, you can see the needle is so close to the optic canal that easily at 41 millimeter we can inject the anesthetic to the optic nerve sheath, causing brainstem anesthesia. So in spite of it being an excellent echinacea technique with very rapid onset of action, still it's very dangerous. So then came the peribulbar, where we have a 26 gauge 25 millimeter needle, also can be given with a 26 and a half needle. It's much safer, but still the risk exists. So the conventional teaching, even when I was doing my residency for peribulbar, was the Atkinson point, where the junction between the medial 2/3 and the lateral 1/3 and the supromedial part. But now we know there are safer sites for peribulbar, that is a lateralmost point at the orbit and in the medial part at the caruncle, because there the globe is safely away from the orbital margins. Now the subtenon block, now this can be done with a needle technique as well as a blunt dissection technique. So let's resort to blunt dissection because it can negate the complication associated with needle technique somewhat. So we make a nick in the subtenon capsule and after blunt dissection inject the anesthetic. And this is the specially designed cannula by Stevens. It is a 19 gauge 21 millimeter cannula with a curve so that it can follow the curvature of the globe. And if you're injecting an anesthetic at around 4 ml, then it will diffuse around the subtenon sheath as well as the extraocular muscle sheath. Now you inject 2 more ml, it will also diffuse to the intraconal space. A little bit more ml, it will act like a peribulbar, giving excellent akinesia to the orbicularis oculi as well. Now, the incidence of complications, if you see the numbers, they are very low, but considering the huge amount of cataract surgery being done, the absolute values can be significant, especially in training centers. Now, the contraindications to LA, when the patient is not consenting, he is not able to comply to our instruction, he is not able to comply to acceptable positioning in the OR, if there is an uncontrolled tremor or anxiety, if there is allergic to the local anesthetic agent, there is a grossly abnormal coagulation, there is sepsis in the area, and in cases of trauma with a perforated globe. Now, the preferred local anesthetic agent, we always mix a short-acting with a long-acting one, lignocaine and bupivacaine. The only issue, the cocktail, we cannot ensure how sterile the solution is. We can negate it by using a single solution of ropivacaine, where it is intermediate in both. Can mix hyaluronidase, epinephrine, as per your choice. Now, with the advent of safe of eco-emulsification systems, smaller incisions, foldable IOLs, the cataract surgeons are shifting their focus to topical anesthesia. Absolutely no risk associated with needle injection. Also meet the high patient expectations, no downtime, immediate results, very affordable. Few tips when we are performing surgery in a topical. Yes, the incision is best kept clear corneal, limbal at the most. Then the operating time projected should be short. And we should avoid office squeezers. That is those patients who are uncooperative when we do a tonometry or indirect ophthalmoscopy. And make sure you anesthetize both the eyes. Avoid deep sedation because we want our patient to comply to all our instructions. So in deep sedation, that might not be possible. Start with a very dim illumination, gradually increase so that we don't startle the patient. Verbal anesthesia, extremely important. Tell the patient, we are going to place the drape, or now you're going to hear the sound of the phaco machine. I'm going to inject the eye oil. You might feel a little pressure. Remember, in topical, it isn't over until it's over. When you're taking the speculum, the patient might squeeze the eye because there is absolutely no akinesia and the AC might collapse. So proper instructions, very essential. And is there any studies saying topical anesthesia has an increased risk of complication? Yes. When compared to the needle techniques and when compared to topical anesthesia combined with intracameral, topical alone increases the risk of PC rent, vitreous loss, nucleus drop, and as well as endophthalmitis. Probably because no akinesia, the incision comes in contact with lashes and fornix, or maybe because of the increase in PCR. So there are certain factors that increase the likelihood of intraoperative pain, patient factors as well as surgical factors. In those cases, we can consider sedation. But in sedation, as I said, patient cannot comply with our instructions, and the airway, if compromised, we won't even know. In that case, a GE is better, especially in young children and in like patients who have psychiatric problems, who has delirium, because they're at least the airway and vitals are under control. Now, the monitored anesthesia care, where you have a qualified anesthesiologist monitoring the patient while you're doing cataract surgery, it might sound as a luxury, but there is data supporting high levels of subjective patient satisfaction as well as surgeon comfort. And the methods of monitoring include communication, then observing the patient, and pulse oximetry if you're doing a topical, and BP and ECG if we take sedation or GA. And all the OT personnel should have BLS training, at least one should be trained in ALS, and we should document the anesthesia procedure, whatever is undertaken. Now, just to summarize a safe practice, pre-op patient counseling, extremely important. Keep the conditions in the OR optimal. Low noise levels, dim illumination, and comfortable temperature. Appropriate patient selection and the case. There is no place for ego. Patient safety always comes first. And monitor the vitals and make sure the equipment facilities are of good standard and maintenance, especially in case of a medical emergency. Now, the search for the holy grail anesthetic still continues. And these are just tips. Now, exception is the rule in medicine. So I just want to share one case. This was a case of chronic liver disease, which I operated around 2 years back. So his INR levels were over the roof, like 3 point something. And then we gave 3 infusions of vitamin K. It refuses to budge. So it was like a diabetic patient, hard cataract, One was like NS4, other was like brown or black. So I thought I'll go for the NS4 first because there was no question of giving any sort of block. It has to be done under topical. So the first eye, I did topical phaco, but that time I didn't have like the best of equipments available. So there was post-operative edema for first few days, but eventually he gained 6/6 vision. For the other eye, I thought I'll do a topical SICS, but the patient was cooperative. It was possible. So even when these tips are taken into account, remember, we can tailor our techniques for every patient. Thank you.
Thank you, Dr. Manasa. I think within a short span, you've covered all the very important aspects of ocular anesthesia. To further the discussion, I just wanted to bring up this point that now, because of a lot of advertising and some relatives who have undergone topical anesthesia, sometimes patients come to us. They may be a very suitable case in terms of anatomy, but if you look at the patient nature, they might have a like very strong bells, and they might start squeezing on table. So, in the pre-operative counseling, you have told, okay, I'm going to do a topical anesthesia. But on table, you realize that it's not possible. Patient is squeezing really hard and there's a strong bells. So, you have to anyway inject subtenons, I think, to be on the safer side. So, how will you counsel at that time? Dr. Manju, you want to say something? Sorry.
So we can very well tell the patient, yeah, if you're not able to look at the light, so while lying under the microscope, you'll have great difficulty. So that will lead to more complications. And so it is better, you can give the choice. It is better to give, do under block. It won't be very painful. You have to counsel the patient properly and give them confidence. Like it won't be much painful. It'll just will have the pain of the injection, that's all. And you'll have to talk to the patient continuously while giving block. See, what you have done is some of the patients, they preoperative will tell, okay, doctor, I'm very anxious like that. If that is the case, then we can take precautions. What I always tell the anesthetist, please keep a paraffin soft cotton tip applicator here. That Kuchi is Dana Johnson's, but so we soak it with paraffin and then just keep on the skin where we are first pricking. So then the initial prick, there won't be any pain for the patient. So after that, we inject little and wait for a while and then inject further. So most of the, and if you continuously talk to the patient, I think patients will will cooperate even for block, topical, whatever it is. But if the patient is very anxious, if they are choosing topical anesthesia because they are very scared of pain of injection, then don't operate under topical anesthesia because they won't cooperate during the surgery. And few things is, yeah, the talk was excellent talk. And then few things are, selection of patients are very important. Like don't take complicated cases, don't take very hard cataracts or mature intumescent lenses. So that depends again on surgeon's confidence. But as a general rule, you should not take very difficult cases when you're operating under topical anesthesia. And high myopes, especially because the risk of glauc perforation is high. So it's better to operate them under topical anesthesia. But again, because the scleral rigidity is low, when you're entering the eye with the infusion, normal infusion pressure, then there'll be stretching of ciliary body, what is known as that CBDSO, they'll have pain. So always supplement with intracameral 1% preservative-free lidocaine when you're operating under high myopes because of the ciliary body stretching, they'll have more pain. And another tip is if you're operating, instead of putting BSS, you can put OVD over the cornea so that there is no need of frequent irrigation of the cornea with fluid because that is the time the patient squeezes the eye. So OVD can be put. And another tip is while doing this, the hydrodissection should be complete because when you're rotating the nucleus, this ciliary sonules, they'll produce some tug on the ciliary body and that can cause pain. So hydrodissection should be very good and the nucleus rotation should be gentle. And always operate with, don't overinflate the chamber with OVD because that will cause the high pressure and then deepening of anterior chamber. So or underfill the anterior chamber with OVD. So these are some of the tips when you are operating under topical anesthesia. And anytime if the patient complain of pain, you have options of injecting subconjunctival xylocaine, you can give subtenants. All these options are there if need arise.
And one more point is, when we are counseling the patients, we should tell them, though you have opted for a topical, depending on the situation, we might have to supplement you with additional ocular anesthesia. Like you might need an injection during the surgery. because sometimes when we counsel on table, it will become a surprise for them. So next I call upon Dr. Sandhya to present her topic on toric IOLs. Dr. Sandhya is a senior cataract surgeon at practicing at Giridhar Eye Hospital, Kochi.
So toric IOLs in cataract surgery, how to optimize outcome. So more than aim of modern cataract surgery is to give maximum free spectacle free vision to the patient and not just removal of cataract. So around more than 40% of cataract population have a cylinder of more than 1 diopter. So not addressing this during cataract surgery will cause patient dissatisfaction. So now we have toric IOLs to correct up to 4.75 diopters of corneal astigmatism. So proper patient selection and acquisition of accurate preoperative patient data and precise IOL calculation and execution of proper surgical plan are critical to optimize toric IOL outcome. So suitable candidates are patients with regular corneal astigmatism of more than 1 diopter. Nowadays we are correcting smaller and smaller amount of astigmatism. So the first patient has regular with the rule astigmatism and the second patient there has regular against the rule astigmatism. So dry eye and ocular surface conditions should be treated before taking keratometry measurements. Now with the advent of optical biometers, accurate axial length measurement is not a problem. But measuring cornea is the major problem in IOL power calculation. So we have to take these precautions. We have to treat the dry eye and ocular surface before measuring cornea. And patients with epithelial basement dystrophies and irregular corneal astigmatism, they should be avoided for toric IOL implantation. And high myopes are not good candidates, and you should have an intact capsular bag to provide rotational stability for the IOL. And you should measure the cornea before putting any dilating or anesthetizing drops. You should avoid drying, pressing or rubbing of eyes, and you should take consecutive identical readings with good signal strength. And you should always avoid measurements with those warning signs. And you should also look at the Myers. If the Myers are missing or irregular, you should not take readings corresponding to that. The subjective refraction should not be taken for toric calculation because it includes lenticular astigmatism, so that is going to be removed during cataract surgery. So this patient with severe dry eye, and she was a rheumatoid arthritis patient, and she had a visual acuity of 636 best corrected visual acuity, and she was planned for a toric IOL, and her ocular surface was looking like this. And then after 3 days after punctal cautery, the cornea ocular surface improved and her vision improved to 6.9. So this shows the importance of treating ocular surface before cataract surgery. And whenever you should repeat the measurements if there is inconsistency between measurement, and if the steep axis is more than 47 diopters and the flat is less than 40 diopters, and if there is high astigmatism of either eye of more than 2.5 diopter, and also if there is asymmetry between the eyes of more than 1 diopter. So topography is helpful in ruling out irregular astigmatism. Now that we have identified the suitable patients and we have taken accurate measurements, now let's move on to IOL power calculation. So basically cornea has both anterior and posterior corneal astigmatism, and anterior cornea has with the rule astigmatism and posterior cornea has against the rule astigmatism. So if you don't address the posterior corneal astigmatism, that will lead to overcorrection of with the rule and undercorrection of against the rule astigmatism. Some of the newer optical biometers and manual keratomies and a topography based system, they measure only the anterior cornea. So why is it important to measure the posterior cornea? Because of the concept that if it is not corrected, the with the rule astigmatism will be overcorrected and the against rule will be undercorrected. So some of the newer biometers, optical biometers like IOL Master 700, it can measure the posterior cornea also. So coming to IOL power calculation, the most widely used formula is Barrett toric calculator. So this is available free online in ASCRS and APSCRS website. So what you have to enter is, you have to enter the K readings, you have to enter the axis of the K and then the incision location and the surgically induced astigmatism. then it will measure and give you the IOL power that is needed, and also it gives the axis of alignment of the IOL, and so it also gives the message of residual refraction if you place this IOL in the eye. Now the significance of surgically induced astigmatism is coming down because the incisions are becoming smaller and smaller, and also because of the concept of centroid. This was assigned a value of 0.1 diopter. So if the patient is choosing a premium IOL, what he can do is, inside the optical biometer itself, this Barrett toric calculator formula is there in most of the biometers, Lenstar, IOL Master, etc. So you can put it into directly into toric calculator. So if there is astigmatism and toric IOL is needed, it will give a print like this. So it will give the power of the IOL and alignment of axis, etc. And if the no toric IOL is needed, it will give a message that not appropriate lens model found. So in that case, you don't have to put toric IOL. So if you get like this, you don't have to think about against rule astigmatism, with the rule astigmatism and all those things. You can straight away send the patient to counsel for toric IOL. And this toric IOL has some marks here that should be aligned with the steep axis of the cornea. And coming to the surgical plan, so these are the things that need to be done in addition to what is being done in a normal phaco. That is, you have to do reference marking. That is, the 0 and 180 should be marked, and this should be in the sitting position to take care of cyclorotation. And then you have to mark the steep axis of the cornea because the IOL has to be aligned in that axis, and then the IOL mark should be aligned with the steep axis of the cornea. So these are the, here I am using a bubble marker for reference marking. So when the bubble is center, you have to mark the cornea at the limbus as shown here. So then it will be 0 and 180. The bubble should be in the center. Now in this, it's a slit lamp based method. So the beam is rotated to horizontal position, and when the Purkinje image is in, ask the patient to look straight, and the Purkinje image is when in the center, you have to mark the cornea when it touches the limbus. Now this patient is lying down under microscope after reference mark. You can see here. So you should mark the cornea and not the limbus, because not the conjunctiva, because conjunctiva is mobile, and the rexus should be round and it should uniformly overlap the IOL so that the IOL position remains stable. And then the clear corneal incision should be very smooth without any ragged edges. And then rest of the things are normal. You have to do a hydrodissection, and the phacoemulsification is like a routine phacoemulsification. And when you are marking the cornea, you should avoid spreading of the dye and smudging, etc. And once the nucleus and the cortex is removed, the eye was filled with OVD, and then you have to mark the axis. That is the degree gauge on this ring is aligned with the 0 and 180 marks. Here the axis is 165 and the steep axis is marked like this. Now the toric IOL is slowly injected, and you have to rotate it clockwise as it unfolds, and you have to stop around 3 to 5 degrees short of the final desired axis, somewhere around 5 to 10 degree, and then you have to unfold the haptics completely so that it settles down well, and then you have to remove the OVD first from behind and then from above the lens, and then finally align the lens to the axis that was previously marked. And then you can just tap the lens onto the posterior capsule so that it remains stable. And also, while hydrating the side port, you should make sure that the fluid weight doesn't propagate under the lens and lift it up, because then there will be change of position. Then here, Virion image guided system was used for alignment of the toric IOL. So Virion, it captures the images of the eye and notes down the details of the scleral limbal vessels and the iris detail. And then it calculates IOL power, and also it makes a surgical plan and creates an overlay which will be projected onto the cornea during surgery. And then after cortex removal, so you have to fill the chamber with OVD, and then you can see here the axis of alignment in 104. So finally it gives that line 104. So you have to align the 3 dots along the line. So here the only one advantage is that you don't have to consider about the fading of the dye or the smudging of the dye spread and all, but it's a machine dependent thing. So machine, you can't depend on 100% always. And sometimes we'll have to customize the IOL. In this patient, So had a keratometry reading of 46.28 at 180 and 55.7 at 30, and astigmatism was plus 9.5 at 38 degrees. And the topography showed features of keratoconus, but since the astigmatism was regular, we went ahead with implanting toric IOL. This was a custom-made lens, plate haptic lens that was customized by the care group, and it has a hole there on the haptic that has to be positioned to the left side while loading the IOL and while injecting it. So this is a slightly heavy lens, it's a plate haptic lens, and that has to be injected very carefully. And then there is no need of axis marking because it is intended to be placed in the horizontal axis. So finally you have to align with the reference marks there. And then finally the patient had a visual acuity of 6.9 with plus 0.75 cylinder at 100 degree. So to conclude, right patient selection and a good preoperative assessment and a meticulous surgery generally ensures good result, but never promise the patient that we are going to give zero astigmatism. Thank you.
Thank you, Dr. Sandhya. I think that was a very beautiful presentation with the lovely videos. One point regarding that customized IOL. I think if we are ordering the customized IOL, toric IOL, we need to counsel the patient that it would take some time,
It
right?
will take some. Usually they give in 3 weeks to less than 1 month time.
Around 1
Yeah,
month.
around 1 month time.
So that is one thing. If you're going for a customization, we need to tell the patient that they'll have to wait. Yeah, wait for 3 weeks. Yeah. Okay. Thank you. So next I invite our next speaker, Dr. Manju. So Dr. Manju is currently working as a glaucoma consultant at Giridhar Eye Hospital, Kochi. And she'll be talking on the topic coexisting cataract and glaucoma, whether we have to go for combined or a sequential surgery.
Thank you, Dr. Ambika, for the invite. I'll be talking on the management of coexisting cataract and glaucoma. Glaucoma and cataract often coexist. So the choices include one is sequential approach, that is, you can do a glaucoma filtering surgery first, followed by cataract surgery whenever indicated. Or you can do a cataract surgery followed by a glaucoma surgery later. Or you can do a combined surgery and do both the surgeries in one sitting. So, what are the things you have to consider before deciding? You have to find out the extent of glaucomatous damage, the stage of the disease, and the presenting intraocular pressure, and what is your target IOP. And do a perimetry to see the extent of the severity of the damage, and consider the number of AGMs the patient is currently on and how the patient is responding to the medication, and make sure the patient is compliant and tolerable with the anti-glaucoma medication, and also the amount of cataract. Other factors which you have to consider include age of the patient, ocular and systemic comorbidities, whether the patient is able to undergo 2 surgeries at 2 different times, and socioeconomic status, whether they are able to afford 2 different 2-stage procedure. So now let us look at the cataract surgery alone. It definitely gives a visual improvement, and it increases the anterior chamber depth and angle width more in angle closure disease, but to some extent in open angle glaucoma also. Intraocular pressure reduction is more in angle closure compared to open angle, and this IOP reduction is usually related to the pre-op intraocular pressure. A study from PGI has shown that the cataract surgery leads to significant drop in IOP across the spectrum of angle closure disease with visually significant cataract. So, cataract surgery alone may be considered initially for IOP control even in advanced or medically uncontrolled primary angle closure glaucoma, followed by glaucoma filtering surgery later if required. So what are the options of cataract surgery? You can do either a phaco or a small incision cataract surgery. So as you all know, phaco takes only a small area for the surgery, and the superior conjunctiva is untouched, so the trabeculectomy future will be easy. But if you are doing an SICS and in the superior quadrant, future trabeculectomy will be difficult. And the complications post-op include the IOP spike will be there in the immediate post-op period, and this you have to manage in addition to the anti-glaucoma medications which the patient is already on. And the post-op CME may be slightly more in glaucomatous patients, and patient has to continue the anti-glaucoma medications which they are already on. Glaucoma filtering surgery alone, it helps to achieve a low target IOP compared to cataract surgery alone. So when you want to have a very low target, you may have to opt for a filtering surgery, and the better success rate compared to combined surgery in if you do a filtering surgery first and then do a cataract surgery. So as you all know, but the problem with the filtering surgery is not the surgery per se, the identification and the management of post-op complications for the success of the bleb. And it doesn't give any visual improvement, rather it may cause a cataract formation or it accelerate the existing cataract, and patient may need a cataract surgery later, which in turn can lead to failure of filtration and decreased IOP control. So if you want to do a cataract surgery after the filtering surgery, you may have to wait for 3 to 4 months after the filtering surgery. You make sure a pre-op low IOP, either use Diamox or mannitol preoperatively in addition to the anti-glaucoma medications. Avoid excessive massage after the block. Sometimes because of the mitomycin, the bleb may very thin, so you have to be very careful. And leave the bleb untouched. Temporal clear corneal phaco is better, and suture the cataract wound is also indicated, and use of NSAIDs post-op. Combined surgery, IOP lowering is better than cataract surgery alone and better visual improvement compared to filtering surgery alone. It also prevents the IOP spikes in the immediate post-operative period because already have done the bleb filtering. It compared to two-stage procedure, the cost will be low, and post-op complications as in cataract surgery alone, and the success rate of trabeculectomy is low when you combine with the cataract surgery. So combined, what are the options? SICS trabeculectomy, phaco-trabeculectomy, and phaco with mix. I don't have much experience with the phaco with mix. Phaco, you can do either a two-stage procedure or single-stage procedure, and two-site or single-site. Two-site approach, the visual improvement is same as single-site or two-site, but the less astigmatism will be less in case of two-site approach, and the IOP reduction may be more. But it takes more operating time and more endothelial cells loss is reported. So let us look at some case scenarios. This is a 56-year-old female who was diagnosed as a primary angle closure disease, which was incidentally detected 3 days back. So we don't have a baseline IOP, and the patient was already on Bimat and Diamox. So BCVA was 618, N18 in the right eye, AC was shallow, lens was showing cataractous changes in the right eye, both eyes. Pupil was showing RAPD in the right eye with the disc near total cupping. Intraocular pressure was 9 mm and 8 mm because the patient is on Diamox TID. Gonioscopy revealed closed angles. So patient underwent YAC-PI in both eyes, and post-PI IOP was controlled with a fixed dose combination of 2 drugs in the right eye and single drug in left eye, and the central corneal thickness was normal. So the lens was around NS2 to 3 cataract with a near total cupping, and the IOP was 10 mm post-PI, and the gonioscopy showed synovial angle closure around 180 to 270 degree. The fields were showing advanced damages in the right eye. So this was a case of advanced PACG with IOP control with 2 AGM with a significant cataract. So in this case, you can opt for a phaco with IOL alone because the cataract surgery alone will give you a reduction in the IOP, and maybe patient may not require these 2 anti-glaucoma medications in the post-op period. So the next case is a 54-year-old male who is a non-case of POAG since 2 years, and initially IOP was controlled with a fixed dose combination of bimetoprost with timolol, and on follow-up the patient's pressures were 20 and 21 millimeters in both eyes, and the disc was showing advanced damage in both eyes with an early lens changes. Gonioscopy, open angles. So we tried to add the medications, but the patient was not responding to adding medications, and the fields were showing over the progression, over the years, some progression in both eyes. So this was a case of both eyes, advanced POAG, IOP not controlled with maximum medical therapy, and the cataract is very early. So we can opt for a trabeculectomy with mitomycin C, both eyes, maybe left eye first, and then can plan a cataract surgery later whenever it is indicated. The third case is a 62-year-old male with diabetes and known case of combined glaucoma post PI 1 year. Patient was on bimetoprost eye drops. So on examination, the best corrected visual acuity was 615 N10 in both eyes, in right eye, and 612 N8 in the left eye. Cataractous lens in both eyes with a patent PI in the anterior segment. The disc were showing advanced damage. IOP was 48 millimeters and 46, and the gonioscopy showed open angles post PI with few PIS. So we tried to add it a fixed dose combination of 3 drugs. IOP reduced to 28 and 23 with maximum medical therapy. Fields were showing advanced damage. So this was a case of combined glaucoma, and the IOP was not controlled with maximum medical therapy, open angles, and there was a significant cataract. So in this case, you can opt for a combined phacotrap with mitomycin C under GVP. So my preference is cataract surgery with IOL implantation alone in case of lens-induced glaucomas, ocular hypertension. In open angle glaucomas with significant cataract, if the glaucoma is mild, IOP is under control with 1 or 2 anti-glaucoma medication, and the patient is well tolerated and compliant with the anti-glaucoma medication. In primary angle closure disease with cataract, if it is moderate glaucoma with mainly appositional closure, IOP under control with 1 or 2 AGMs and well tolerated with medication. Glaucoma filtering surgery alone in case of very advanced glaucoma, moderate to severe glaucoma in case of failure to achieve target IOP despite maximum medical therapy, if not tolerating AGMs or poor complying with AGMs with an early cataract changes. Combined surgery, visually significant cataract with moderate to severe open angle glaucomas with more than 2 AGMs, failure to achieve the target with maximum therapy, or not tolerating or complying with AGM. And if 2 surgeries at different times not feasible. Thank you.
Thank you, Dr. Manju. You've summarized all the points really well. I think.
I have one doubt. Like, is there any preference for any type of OVD during when you're if you're doing combined surgery, like dispersive, cohesive, if it is retained?
Maybe combined surgery, even if you need the cohesive in, I think it won't be a problem, because I usually use cohesive once the cataract is done. Then I put the cohesive viscoelastic to complete my trap, and maybe if I'm feeling it is shallow, I may need a bit of cohesive in the inside, so that most of shallow will be less.
Okay. And then any change in the regime of steroids that you give postoperatively if you're doing a combined case compared to normal cataract?
Yeah, whenever you are combining with the filtering surgery, I think you need a long-term course for the steroids. I usually give 2 hourly for 1 week, and then give a 2 weeks tapering, 6, 4, 3, 2, 1. So it may go for a little longer time.
Thank you.
Doctor, you had a question. You had a question, Doctor? Yeah, you please come.
So when we leave for cataract surgeons, we are very scared of getting holes inside the eye, any viscoelastic inside the eye at the end of surgery. We take quite a lot of meticulous time to make sure that behind the IOL, in front of the IOL, sulcus, angles, everything is washed off. But I've noticed that most glaucoma surgeons say that this is a good thing to leave a little bit if you feel that it may overfilter. So what about the post-op inflammation? Do you see that there is more?
Cohesive, I have not seen much of post-op inflammation more, but HPMC I have seen. So I don't use HPMC. Once the cataract is done, then from behind the IOL and bag I will remove, and then in the AC I'll put Kohi, and while completing the surgery, and I try to wash off most of it, but sometimes I leave in Kohi back, so that immediate post-op hypotony won't be there.
And one more thing, the prostaglandin analogs, before you start surgery, do you shift over to any other thing, or is that?
Some people say, but I usually know. But I start Predfort 1 week prior QID.
Okay, so you don't normally stop.
Usually, when I opt for a filtering or a combined, the patient will be already on maximum medical therapy, and the pressures were maybe 30s or 40s. So I don't have a choice to withdraw PG analog, and anyway I'll be giving Diamox. So I start steroids and continue the prostaglandins. In post-operatively, intraop, if there was any complication, if cataract alone is considered, then maybe post-op I may have to change the PGA to some other AGM if it is cataract alone.
Okay, and one last question. Sorry. One last question. Would you do PI in a patient who's got less than 180 degrees sine K, but you're planning a cataract surgery? Would you do a PI anyway before that?
In an angle closure, I prefer to do a PI before cataract surgery,
Okay.
so that it will give some space and chance of getting an acute angle closure while waiting for the cataract surgery after dilatation may be also less.
Thank you.
Thank you, Dr. Manju. I invite our next speaker, Dr. Shaji Hussain. Dr. Shaji is a cataract and refractive surgeon practicing at Abate Eye Hospital, Perintalmana, and also he visits the Calicut Center. His topic will be cataract surgery in a compromised cornea.
Good morning, everyone. As you can see, the topic is about how to go about with cataract if you have a compromised cornea. So to begin with, the four main things wherein you have a compromised cornea before doing a cataract surgery, most of us would be facing a keratoplasty patient, a patient who has already undergone a refractive surgery, who is having Fuchs endothelial dystrophy and keratoconus. So the first thing to strike in keratoplasty is about the sutures. Remove the sutures, wait for 3 months, and then go about and go with your biometry. Refractive surgery, the two main concerns are which formula to apply and what IOL type to be placed in. In Fuchs endothelial dystrophy, it's definitely the grade and the count of the endothelium cells that's important. And in keratoconus, how smooth the cornea is. So to begin with, as I said, keratoplasty, remove the sutures, do the biometry. If it's already a hard cataract you're dealing with, better to go about with this small incision cataract surgery because less trauma to the endothelium. Now, let's say you are going ahead with in early stages. Usually, keratoplasty cataract is usually the patients are on steroids and the patient may be having usually most commonly PSC. So you're usually dealing with a soft cataracts initially. And here definitely it is the endothelial protection that has to be kept in mind. So you do quite and you have to use the dispersive visco. Make sure the rexus is well controlled. You can't afford to have an extension here because as such the endothelial counts and much of manipulations we have to be very careful here. Do a controlled rexus and then by making the incision make sure you are not involving the graft post junction. If you are a beginner you can always go with a sclerocorneal incision and ensure you have a good and when you are using the phaco ensure you are using it in a low power mode. And next is to dealing with keratoconus. You have, as I said, you have to deal with see how smooth the cornea is and in what stage of keratoconus you're doing the cataract surgery. So in that it is the formula that I'll be dealing with later. And the IOL, you can ideally speaking safer to go about with the spherical, but you have now toric and even high toric lenses that can be customized. Ideally, the available toric powers would be -6 cylinders, but if you can customize it, as in the previous speaker said, even up to 14 diopters and all can be after customizing it. So the con position, if it's central, you can go about easily, but if you have a decentered, then you have to counsel the patient accordingly. And post-surgery vision, you can never guarantee a 6/6 vision. It always depends on how much the patient will be seeing post-operatively only. And even while doing the surgery, the view is something you have to look at because you may have excessive reflexes from the thin cone. If you are already dealing with a patient who's having an advanced keratoconus, it's ideal to go about with DALC and then do the suture removal, wait for 3 months and then plan the cataract surgery later. If the patient develops a cataract later. If you already have an advanced keratoconus with opacity, you can even plan a triple procedure. With regard to the IOL, the standard approach is if you go about with the normal formulas, there are high chances you can end up the patient in hyperopic surprise. And usually the patients prefer after cataract surgery, it will be better to go target a myopic power. So if you are dealing with a mild to moderate KC, you can always go about the SRKT and keep a target myopia of -1 to -2 to be on the safer side. But if you are already dealing with a severe KC and you don't know what would be K would be, plan an SRKT with a standard K of 43.245. And also now the Kane KC, Barrett 2 KC are all giving promising results, but it cannot be yet conclusively evidenced and not yet confirmed. So what is refractive surgery got to do with the formula? Here the main two things you are dealing with is the compromised anterior corneal curvature, and you know when a variation would result in a 1 diopter IOL, and the prediction, the difficulty in predicting what would be the effective lens position would be. So if you go about, usually if it's a myopic patient who has undergone a refractive surgery, you can always end up predicting an hyperopic shift. So the instrument error here would be in a post-refractive surgery, you know it is only the central zone that is being estimated, and even in the central zone in a post-refractive patient you have different curvatures at different points. And the machine will be calculating it at 3.2 millimeters, but you know at the central areas the curvatures are quite different. So again you will be in a myope, you will be underestimating the power and making him hyperopic. So what is all the trouble here is the refractive index being considered in all the IOL formulas it is 1.337. But you know that this in a curvature, normal curvature, that is fine. But here in a post-refractive patient, you know it is flattened surface anteriorly, and this relationship of refractive index of 1.337 is no longer standing. And hence, there are various formulas that are available, and the things that is gaining importance is the equivalent K reading that can be calculated in the pentacam, and here you know it is actually the 4.5 area and the EKR65 mean that is usually taken up as the K value. So the formula error, again it will the effective lens position would be wrongly calculated to be positioned more anteriorly in the formula if you are not keeping this in mind. And there are a lot of other formulas that can be kept. So the main thing here, or the easier way out, would be to use the ASCRS calculator. This is the website that you can go into, enter the values and give your patient details, and the formulas will just be given, and you can always go for the average IOL power or the maximum. So the question is about premium IOLs, can it be implanted? So it always depends upon how it should be a well-centered ablation. There should not be an excessive higher order aberrations present, and it should be in the latest generation of refractive machines that the patient has undergone. Then yes, there are thoughts about placing a extended EDOF lenses and even this Synergy platform lenses. So in conclusion, always make sure the premium IOLs consideration has to be, if you're a starter, it's always good to go about with the single vision distant lenses. And the next question would be about fuchs endothelial dystrophy, and here the question is whether I should be planning phacoemulsification alone, or should I be combining it with an endothelial keratoplasty? Well, to consider that, it would be always better if you have subomitral endothelium with cataract. Phacoemulsification can be considered, and then plan a second stage endothelial keratoplasty. The next thing would be, when do I go about with a triple procedure? I can plan DSEC with phaco, or I can plan PKP with ECCE. Now, what are the three things to be considered here is the PACI has to be according to the relationship with the thickness of 650 microns. I'll tell you when and how good the view is for the surgeon, and how is the endothelial count. Is it above 1000 or not? So in fuchs endothelial dystrophy, if you are looking at a thickness that is less than 650 with a good endothelial count, you can go about with phaco alone, but the counseling has to be done well, that the patient may need a endothelial keratoplasty at a later stage. Now, if it is 650 less than 650 with cell count of less than 800, then you have to be in the second level of counseling for the patient, that he may need it very soon. And if you're already dealing with a thick cornea that is more than 650 microns and the cell count of that is less than 800, then it's always ideal to go about with both together. So this is again just as we did in a PKP, we have to take care about the endothelial count. And the other conditions where you may have trouble is you have central corneal opacity with cataract. You can plan a triple procedure. If you are looking at a dry eye, always treat the dry eye first. Otherwise, you will end up with patients who will keep eating your head. And if you have a service problem like a pterygium, I always do the pterygium first, wait at least for 6 weeks and then plan my biometry. Herpetic keratitis, you will have to cover the patient on antiviral drugs, wait for at least 2 to 3 weeks and then monitor the patient even post-operatively. Bell's palsy, exposure keratopathy is one thing you have to keep in mind, and ensure you may have to do a tarsorrhaphy if the eyelids are not closing fast. And in immune keratitis, it's always ideal to do the cataract surgery under steroid cover. With that, I thank you all for your patient listening.
Thank you, Dr. Shaji. As we are running out of time and Dr. Shaji has a session next, I think we can take the questions later. So,
May I invite the final speaker of our IC, Dr. Ambika Shetty. She is a cataract and refractive surgeon. The ophthalmology department at Geetanjali Eye and END Hospital is a brainchild.
So, a warm good morning to all of you. The previous speakers have covered most of the important topics. So, with the variety of options for multifocal lenses, we need to have a good idea about the current technology so that we can help the patient take the right decision. So my talk would cover decision making, analysis of factors, and the challenges faced by the surgeon. So this is a patient, Mr. Babu. So Mr. B, he spends most of his time outdoors and he's never worn spectacles before. Apart from his cycling, gardening, and doing other manual activities, he also spends very limited time reading newspaper. So we also know that in the traditional classification, there is refractive and diffractive. And also now we have other options such as extended depth of focus, trifocal, enhanced monofocal, amongst various others. So coming to the refractive design, there is an annular zone of near addition, but the disadvantage is that it is pupil dependent. In the diffractive design, there are multiple concentric rings. The advantage is both distance and near visual acuity is gained, but then there is a loss of contrast. With the extended depth of focus, there is an added advantage of getting better intermediate vision. Also, we have other technologies such as quadrifocal, enlightened technology, achromatization, wavefront shaping technology to enhance the patient experience and also minimize the dysphotopsia, glare, and halos that were present present in the traditional multifocal lenses. So when we speak about enhanced monofocal, so the asphericity in the anterior corneal surface, anterior surface of the lens gives a patient a little bit of intermediate addition as well. So without patient experiencing glare and halos, he can expect a spectacle independence in 72% of patients and intermediate vision in spectacle independence in intermediate vision in 72% and 38% for near vision. Coming to the factors that influence in decision making, it is important to understand the patient preferences, whether the patient likes night driving, what is the kind of patient personality, what is the ocular health, and also make the decision based on the surgeon's experience. It's important to explain the benefits and limitations, set realistic expectations, explain the patient regarding halos and glare, and also explain that in certain situations, patient may still need glasses. Beware of difficult patient personalities, patients who are highly critical, have high visual demands, who are also extremely meticulous in describing their visual impairment. And when we come to the ocular health assessment, it's important to understand whether the patient has a dry eye, also rule out any meibomian gland dysfunction, understand by feeding the data in the Barrett's toric IOL calculator whether the patient needs a toric IOL, and avoid extremely high refractive errors, and also identify subtle anterior segment pathologies, any hidden corneal dystrophies, and also it's important to understand what is the scotopic pupil size. And one more important thing is any hidden pathology in the capsule or zonules, like subtle pseudoexfoliation, must also be picked up. In certain situations, it may be necessary to do specific tests such as specular microscopy to understand whether the patient has any guttae, and a corneal topography to identify whether the patient has any subtle keratoconus or increased increase in the aberrations. Also, in certain situations, it may be necessary to understand whether the patient has a high angle alpha, and also in certain situations, it may be necessary to do an OCT to pick up any subtle macular pathology. Based on the surgeon's experience, one can discuss with their colleagues and also understand and get a better idea about which IOL would be suitable for a particular patient. It's important to anticipate and manage potential complications. And also, it is important to be updated with the latest technology so that we can take the right decision. Most important is an accurate biometry and use of third generation formulae, target low hyperopia, target for a well-centered capsulorhexis, aim for a careful cortical cleanup, and in the bag placement of IOL. In the postoperative period, the patient has to be counseled that regular postoperative visits are needed because sometimes neuroadaptation may take up to 2 to 3 months. It's important to identify any potential complications such as PCO or cystoid macular edema. These conditions may be actually contributing to the low visual acuity or the patient dissatisfaction. So it's important to keep your eyes open for that. In very rare situations, if there is IOL opacification, one must be prepared for IOL explantation. Also, sometimes extremely dissatisfied patient, one has to be prepared for that as well. Coming to my case studies, I spoke about Mr. Babu, who was a manual laborer and he wanted to get rid of his spectacles. So, following a refractive IOL implantation, patient developed uncorrected visual acuity of 6/12 in one eye and 6/9 in the other eye, and his near vision acuity improved to N6 in both eyes. So, patient is now happy and comfortable and he is able to do most of his activities without glasses. So we need not actually limit our multifocal IOL practice only to patients who can afford higher cost. We can also offer it to patients who do most of their activities outdoors and a limited amount of reading as well. So coming to the second case of Mrs. M. Mrs. M actually has her children living overseas. So she spends a lot of time on her tab. So her request was that she wanted a multifocal lens or a lens which would give her spectacle independence when she uses her tab. So Mrs. M also had a significant toric power when we calculated her, when we did her biometry. So her, we advised her to undergo trifocal toric IOL. So patient developed visual acuity, uncorrected visual acuity of 6/6 in both eyes and a near vision of N6 in both eyes. And now the patient is spectacle free for distance, intermediate and near. And also her relatives are now making fun of her that she looks much younger without her spectacles and she should just wear it to look good. So the next case is Mr. G. Mr. G is also a person who's using computers, and he is on prostate medication. So he wanted a lens which would give him spectacle independence for computer use. So we suggested an extended depth of focus lens with the wavelet technology in the first eye. Following the surgery, he had an uncorrected visual acuity of 6 by 6 for distance and N6 for near. But unfortunately, he was very upset with the dysphotopsia. Every time he came for follow up, he would tell he sees a lot of rings, and he was unhappy. Though the visual acuity on our Snellen's chart, it was showing N6, 6. So, despite counseling on the second eye, the patient wanted to go for a conventional IOL, and he underwent a monofocal enhanced lens, and now he's happy with the post-operative outcome. So when we look at the ESCRS clinical trends survey, we see that the trifocal lens are the one that gives maximum satisfaction to the patient in near, intermediate, and distance. The extended depth of focus and the other lenses are also satisfactory in the near, distance, and intermediate vision. And chances of having functionally high visual aberrations are maximum with the so having visual aberrations is high with the conventional bifocals and lesser with the newer lenses, that is the extended depth of focus and the trifocal lenses. Thank you.
Thank you, ma'am, for the comprehensive presentation. I thank all the speakers for the IC and all our listeners.